Okay, it's 9:33. I'm going to get going. Good morning and welcome. Welcome to our HIV Center Grand Rounds. And I guess I can still say Happy New Year to everyone. First time we're meeting in 2023. I hope many of you, most of you, all of you have had some kind of break over the holiday period, and happy and healthy New Year to everyone. As always, if anyone wants to indicate that they have an announcement to make, please just let us know. Otherwise, I'm just going to let you know about our next Grand Rounds this month on January 26th. We have Steve Shoptaw from UCLA and Jeremy Kidd from Columbia talking about integrated strategies when addressing methamphetamine use among men who have sex with men living with HIV or with HIV risk. So please join us on January 26th for our next rounds. If there are no other announcements from anyone about upcoming events, I'm going to get right to today's event. It's becoming one of my favorite of our Grand Round series with our alumni of our very dear former postdoctoral fellows. And of course, we have two of them here with us today. And first up will be Dr. Alissa Davis, who is an epidemiologist and an associate professor at Columbia University School of Social Work. Her research focuses on the development of interventions to improve linkage to and retention and care for HIV, STI, and substance use services for marginalized and vulnerable populations. This includes racial, ethnic, and sexual minorities, people who inject drugs, and adolescents and young adults. And her research integrates both quantitative and qualitative methods, and she's worked domestically, internationally, in Eastern Europe and Central Asia and China. And we're going to hear about some of that work today. So thank you so much for being with us, Alissa. I'm going to turn the floor over to you.
Thanks, Bob. Thank you for inviting me. Let me just share my screen. Let's see. Hopefully everyone can see slides. If not, stop me and let me know.
Yes, we can see.
Looks okay, good. Perfect. Thank you everybody for coming. I'm really excited to talk about our Jazz Spark study, which means Young Spark in Kazakh. I'd first like to start by thanking NICHD and the Fogarty International Center for providing funding for this study. And also thank our very large US-based and Kazakhstan-based investigative team who've really helped pull everything together, including about 25 youth and community steering committee members and approximately 20 youth volunteers in Kazakhstan. So just to orient everyone, for those who may not be familiar with Kazakhstan, it's a very large country bordering Russia, China, and other post-Soviet Central Asian countries. And you can see down here below that Afghanistan is just south of Kazakhstan. And so there's a lot of drug trafficking that goes through Kazakhstan on the way to larger markets, which is what fuels the HIV epidemic in the country. So the first phase of this study, the crowdsourcing phase that I'll talk about today, was conducted nationally. But the second phase of the study, when we will conduct a randomized control trial to test the efficacy of the intervention, will be conducted specifically in Almaty, which is the largest city in Kazakhstan and is located in the southeast. So globally, as you can see from these most recent UNAIDS data, rates of new HIV infections across most of the globe have decreased or remained stable. However, the major exception to this is Eastern Europe and Central Asia, which has seen a 43% increase in new HIV infections from 2010 to 2020. And it's also the only region that has seen an increase in AIDS-related deaths. And then within Eastern Europe and Central Asia, Kazakhstan has had the largest increase in HIV infections. So they've had an increase of 73% since 2010. And HIV infections in Kazakhstan are still disproportionately concentrated among marginalized and key populations, such as people who inject drugs, sexual and gender minorities, and people who trade sex. But as you can see, adolescents and young adults are also heavily impacted. by HIV. So in Kazakhstan, 1 in 4 new HIV infections occur among adolescents and young adults, and those rates are projected to continue to increase. This graph here on the left is from the National Republican AIDS Center in Kazakhstan. I unfortunately wasn't able to translate the bottom, but each of these columns indicates a different region of Kazakhstan. The graphs or the bars in blue are 15 to 19-year-olds, and the ones in red are 20 to 29-year-olds. And the column that has the highest blue and red graph, that's the Almaty region. So you can see about 16% of HIV infections in Almaty occur in 15 to 19-year-olds and about 18% in 20 to 29-year-olds. And adolescents and young adults have low HIV testing rates in the country compared to other groups. And a major reason for this is HIV-related stigma. So there's a lot of misperceptions about HIV, and people think that HIV is something that only impacts people who inject drugs or gay men. And so there's no need to get tested, and there's a lot of stigma attached to testing. There's also stigma related to the location of testing. So traditionally in Kazakhstan, HIV services are very siloed. And the place to get an HIV test is at a city AIDS center, where it's immediately obvious if you're going there what you're there for. So if someone sees you walk in there, they immediately will assume that you're HIV positive, or if you're getting tested for HIV, that you must be a person who injects drugs or a gay man, or be having premarital or extramarital sex. So the aim of this study was to decrease stigma around HIV testing to increase testing uptake among adolescents and young adults. So as we know, stigma is complicated and can manifest in many different ways, from actually experiencing stigma, and then you have perceived stigma in the community, as well as witness stigma and anticipated stigma or the fear of stigma, and then internalized and intersectional stigma. And in terms of HIV testing among adolescents, the manifestation of stigma that's most salient is anticipated stigma. So that's what we are focusing on as our primary outcome for this study, although we're also taking measures of other types of stigma as well. So to conceptualize the study, we used an HIV stigma framework put forth by Laura Nyblade and colleagues. As you can see, uptake of the different steps in the HIV care continuum is negatively affected by these different manifestations of stigma. And then these manifestations of stigma in turn are driven by what they term as key immediately actionable drivers or causes of stigma. That includes a lack of awareness of what stigma looks like and why it can be damaging, a fear of acquiring HIV just through simple casual contact, and other stigmatizing attitudes. And so one way to decrease stigma manifestations is by addressing these immediately actionable drivers of stigma, which is what we aim to do in the JASSPARK study through crowdsourcing. So we had 2 study aims. The first was to develop a crowdsourced digital HIV stigma reduction and self-testing intervention for adolescents and young adults in Kazakhstan. And then the second is to pilot test the crowdsourced intervention to determine its efficacy in decreasing HIV stigma and increasing HIV testing among youth in Kazakhstan compared to standard national and city AIDS center materials. And so I'll just talk about the first aim today, since that's the phase of the study that we've completed. We're in the process of starting recruitment for the randomized control trial. So I hope to have results from that this summer. For those who may not have heard of crowdsourcing before, crowdsourcing is when a group of community members, researchers, and professionals work together to solve a problem and then share solutions with the public. So as opposed to the traditional top-down approach to developing interventions, where experts come up with the idea and then they field test them, and there may or may not be some level of consultation with local communities. Crowdsourcing is a bottom-up approach where the ideas come from the community members themselves. The ideas are then submitted to a creative challenge and judged, and the best ideas are implemented and shared. So we have a very large number of community collaborators on this study who have been involved from the beginning of the study and have provided really invaluable feedback throughout the whole study. Our community steering committee consists of local AIDS center healthcare providers, staff from youth NGOs and youth health clinics, media professionals, and then we also have 8 youth themselves who are on the steering committee, who have experience working on issues related to HIV or have experience living with HIV themselves. And they've provided a lot of feedback on study design and protocols and procedures on crowdsourcing materials. And then we also have about 20 youth volunteers who reached out and were interested in becoming involved in this study. And so they have done a lot of advertising of the study on social media. They've created promotional videos for the study to get people to submit content. They provided feedback on a lot of our crowdsourcing materials and procedures. And then we've also done cognitive interviewing with them for survey measures to get the surveys ready and tailor them appropriately for this population. So the first phase of this study was to develop a crowdsourced intervention as a quick overview, and then I'll go into things in more detail. We posted an open contest call on our study website, as well as on a number of social media accounts that were created and managed by our youth collaborators. We expected that we would receive about 50 submissions. Submissions then received feedback and suggestions for improvements, and contestants were given time to revise and resubmit their content if they wanted to. The submissions were then judged by a judging panel, and scores were averaged, and the top entries were selected for inclusion into the intervention package. So in order to be eligible to submit to the contest, contestants had to be between ages 13 to 29. They could submit in Russian or Kazakh as an individual or as a group, and we did allow them to submit more than one submission. The main submission categories were audio, video, image, and text, and we tried not to be too prescriptive in telling them what they could and could not submit, so we just gave them kind of an overall topic that submissions should be focused on reducing HIV stigma to promote HIV testing. As it turns out, that was a little too vague, and we had to provide additional guidance later on. So for prizes, all participants who submitted content received a participation certificate. This was something that was very motivating for youth and was something that we actually received as a suggestion from our youth advisory committee as something that they wanted. The entries were divided into 2 age groups, 13 to 19 and 20 to 29, and then we gave top 3 prizes in each age category. We also awarded a top prize for best Kazakh language entry in each age category. And then honorable mention awardees received prizes as well, and honorable mentions were just selected by judges who made notes that they really liked a specific entry and thought that they might deserve a prize. And we had about 17 of those. So just as an overview of the judging process, each submission was judged by a panel of jury members consisting of 2 adolescents and young adults and 2 somewhat older adults from a city, one from a city AIDS center and one from an NGO or international organization. We made sure that each jury member didn't judge more than 10 submissions, and then judging was on a 5-point scale. So each submission was judged on the potential to reduce stigma associated with HIV testing, on innovation, relevancy to youth, and then just an overall score that wasn't necessarily tied to the other 3 criteria, but was just based on judges' overall impression. Scores were averaged across all 4 criteria, across all 4 judges, and then the finalists were selected based on those scores. So we promoted the contest online because of the COVID-19 pandemic. We launched the contest on World AIDS Day, December 1st, 2021, and promoted the contest through a number of different social media outlets. We also conducted live streams and Zoom meetings and developed a study website with information about the contest, and that also had a submission portal. We also held meetings with students at various universities in Kazakhstan. And unfortunately, due to the unrest in Kazakhstan last January, where the internet was blocked for 2 weeks, We had to extend the submission deadline to February, and then due to the invasion of the Ukraine and the geopolitical situation in the region, we ended up extending the deadline again. So the submission deadline actually ended on March 31st, and then we gave people about a month to revise and resubmit their entries if they wanted, and then we conducted judging. So you can see that we had about 4,000 website visits with about 3,000 unique visitors, and ended up with a total of 82 contestants submitting. We ended up with a total of 102 submissions, which was double what we expected to receive. So we were very happy about that. 18 people submitted 2 entries, and then we had 3 people who had submitted 3 entries. And we actually had pretty decent national representation in the contest. So we received entries from every province in Kazakhstan except for one. And then about a third of contestants submitted video, about a third submitted pictures, and a third submitted text. And then we had some audio submissions and a few unique submissions that didn't fall neatly within either of those categories. So things like a crossword puzzle. We had someone who developed a chatbot. We even had someone who developed an online video game that I was not able to win, but they got really creative with some of their entries. So most people submitted as an individual and submitted entries in Russian. Our contestants also tended to be younger. So 65% of our contestants were between the ages of 13 and 19. Each submission was reviewed by our investigative team in Kazakhstan to determine that they met contest criteria and that there were no problems. And some submissions had problems, and some of those were minor, just like an incomplete submission and they forgot to upload their file, or there was poor audio quality that needed correction. But others had kind of more major issues. In particular, there were 11 entries we had that had stigmatizing content or language themselves. And this wasn't intentional, but generally was around in their eagerness to convey that anyone could potentially become infected with HIV, they greatly exaggerated the risk for HIV transmission. So for example, we had one video that someone submitted where there was a kid boxing before class and he had blood on his knuckles, and then a girl was getting her homework together and she got a paper cut, and they were rushing to class and ran into each other in the hallway and touched hands, and then someone comes out and says, oh, you could be infected with HIV, you should get tested. So that's problematic for a lot of reasons, especially because there's a lot of stigma still in Kazakhstan around HIV positive kids attending public schools. So the team had to give feedback to some submissions like that and explain why this type of content is stigmatizing and give people a chance to resubmit. So 89% of contestants received feedback because they had problems of some sort, and then 38% of those resubmitted their work. So I'll show the winning entries. Oh, wait. Maybe before I show winning entries, I'll see Emily has a question. Can you tell us more about the process of selecting and retaining steering committee members for this study, and how you incentivize participation or recognize members' contributions? So with the adolescents, most of them wanted to contribute for college purposes. And so we just gave them participation certificates. The only time we paid people who were submitting or who were participating in the steering committee was when they did the judging. Okay, let me stop sharing quickly and switch to the videos. So this one is the winning entry for the 13 to 19-year-olds.
Смешно. Это тяжело принять. Часто неприятные мысли затмевают голову. То, что случилось с тобой, может сломать каждого. Но не тебя. Потому что ты знаешь, что твои родные и близкие будут рядом. И ВИЧ этого не изменит.
Знакомьтесь, это Алия.
And then this one is the winner of the 20 to 29-year-olds.
Знакомьтесь, это Алия. У нее плохое зрение, поэтому она носит очки, принимает витамины и чувствует себя хорошо. А это дядя Оскар. У него астма. Он использует ингалятор и делает дыхательные упражнения и лечебную физкультуру. И наш главный герой Алан. Он ВИЧ-положительный и получает эффективную антиретровирусную терапию. Алия, дядя Оскар и Алан постоянно консультируются со своими лечащими врачами. Но в отличие от наших героев, Алан продолжительное время не хотел тестироваться, а после раскрывать информацию о своем статусе в связи с внутренней стигмой и возможной дискриминацией в обществе. Несмотря на все сложности, Алан собрался и принял активную позицию в борьбе со стигмой вокруг тестирования на ВИЧ. И сейчас расскажет вам 5 причин того, почему важно пройти тестирование на ВИЧ. Во-первых, положить конец своим страхам и неопределенности. Если в вашей жизни были ситуации, связанные с риском передачи ВИЧ, сдав тест, вы узнаете свой статус. Во-вторых, подготовиться к зачатию и родить ребенка без ВИЧ, даже если окажется, что ваш ВИЧ-статус положительный. В-третьих, вовремя начать получать необходимую медицинскую помощь, регулярно проходить антиретровирусное лечение и предотвратить развитие СПИДа. При этом, чем раньше вы узнаете о своем статусе, тем больше шансов продлить свою жизнь и улучшить ее качество. Сегодня это возможно даже в случае позитивного ВИЧ-статуса. В-четвертых, предотвратить передачу ВИЧ другим людям. В-пятых, жить полноценной жизнью, ведь тестирование на ВИЧ дает возможность провериться на другие заболевания. Тестирование на ВИЧ и снижение стигмы вокруг этого является важным шагом в борьбе со СПИДом. Ты очень важен. Поэтому вот список действий, составленных нашим другом Аланом, благодаря которым ты можешь снизить стигму вокруг тестирования на ВИЧ. И помни, важно знать и не бояться.
So those were the winning entries from each age category, but we actually had a lot of really good submissions and had to really make some tough decisions about what other submissions outside of the top 3 in each category we would include and which ones we just didn't have time for. So the next step is the pilot randomized controlled trial, and we're currently entering that phase right now and starting recruitment. So we will recruit 168 adolescents and young adults from Almaty between the ages of 16 to 24. They must be sexually active, which we are defining as having sex within the past year. They will be randomized to either the intervention or control arm, complete the baseline survey, and then they will either receive the digital crowdsourced intervention content, or they'll receive content that was developed by Kazakhstan city AIDS centers and national AIDS centers. And so they will receive content weekly for 5 weeks. And they'll also complete a follow-up survey at 1 month and 3 month post-baseline. And throughout this time period with each survey they receive, there will be a link where they can order an HIV self-test kit, which will be mailed to their house, or they can choose to pick it up at something similar to like an Amazon locker situation, or they can also choose to pick up a self-test kit at a partner NGO that we're working with. That's all that I have now. So I guess.
Thanks so much, Alissa. That was really great work that you shared, and really impressive to see those submissions. So we will jump into the Q&A portion right now. We answered Emily's question. We have another question from Christina. How did you help young people prior to the competition to understand your definition of stigma, since this is not an easy concept for everyone to understand in the same way?
Yeah, that's a great question. And that was actually really difficult. So we thought we had given an adequate explanation of stigma that we had pulled off of basically UNAIDS and WHO resources and shared. But once we started receiving some of the initial submissions, in particular, some of the submissions that were stigmatizing, that's when we realized that maybe we hadn't really explained things as well as we thought we had. So we actually added examples on the website of what stigmatizing content around HIV looks like. So types of language that you should avoid using, kind of concepts that can be stigmatizing, things like exaggerating HIV transmission or providing inaccurate information about that. And then we also held live stream events that people could attend where people talked kind of more about what stigma was. And then we also had some youth who were living with HIV themselves, and they did kind of interviews with people as well. And we had pretty good attendance at the live stream events. So a lot of the live stream events were hitting 80 to 100 people. So that was, I think, something that was very helpful in getting information out.
Thanks, Alissa. And thanks, Christina, for your question. A reminder, everyone, if you have a question for Dr. Davis, you can enter it in the Q&A feature or raise your hand and I will unmute you. Teo, go ahead.
Thanks, Alissa. Fascinating to see what you're doing. I'm a little bit puzzled though, and I would like to hear from you your thoughts about this. In a way, there is a very large literature about behavior change, and with a lot of technical terms and technical phrases, and it's in a way it's a whole profession with a whole theories about what to do, what not to do. And some of these things are tested, other things are more ideas that people have. And you, in a way, didn't go for that. You, in your study, you wanted to give the power to the people who you want to reach. But at the same time, if these interventions have to be effectful, there has to be a logic behind it, why what they propose to do will have an impact. And I was wondering what your philosophy is, or what your ideas are about how to bridge that gap between, say, the official literature about prevention and having this crowdsourcing approach. You have thoughts about that?
Yeah, no, I think that's a great question. And I think crowdsourcing isn't a magic bullet, but I think there can still be theory involved. So, I mean, for example, we drew upon like the theory of planned behavior, like you actually have to know that you need HIV testing in order to get HIV testing. So I mean, theory plays into it somewhat, although perhaps not as much as some other NIH grants that are very heavily theoretical. But I think where crowdsourcing can really be helpful is in developing tailored materials for populations that you're trying to work with that are actually like appealing and relevant to those populations. I think so often as researchers, we come in from an outside perspective, trying to develop materials for different populations that we know very little about and we're not a part of. And then there's no uptake or there's little retention because they're just not appealing. I'm, not a young adult anymore or an adolescent. I don't know what's appealing to youth in the US, let alone in Kazakhstan. And so I think for us, it made sense to let them kind of develop materials that would hopefully be more appealing and encourage more youth to get tested than materials developed by us or materials developed by health agencies in Kazakhstan. Now, there are challenges with that. Like we did have some submissions that were actually stigmatizing. And so I think it's a delicate balance and a process. And I think this is where it's important also for the community to work in synergy with researchers who also are more aware of theories and perhaps know a little more about what's stigmatizing, what's not. Yeah.
Thank you. Thanks.
Thanks, Teo. We have a question from Phil. Phil, go ahead.
Hi.
Hi.
Great talk. Yeah, I mean, I was maybe you said this and I missed it, but I was thinking, like, given the number of submissions you had, and like this is a relatively small project, like the theory behind that behavior change is actually pretty strong, right? Like people are actively engaging with this content, you raised awareness. So actually the creation of the content itself is strongly, that would be like cognitively changing people, people are engaging with these issues in a way. So I feel like that's super exciting too.
Yeah. Yeah, definitely. And I wish we unfortunately didn't have the resources or time in this study to look at outcomes among people who had submitted content, but I suspect that actually developing the content would be more useful in reducing stigma among people than just viewing the content. Of course, people who submitted content are still eligible to participate in the RCT, and we are asking whether they submitted content, but I don't think we'll have a sample size large enough to actually tease out whether there's a differential effect size there.
Yeah, I mean, even like qualitatively, like, the people who submitted and then resubmitted, right? Like that's showing you can see the learning process there, right? Potentially. So just exciting stuff.
Yeah, thanks.
Thanks, Phil. We have time for one or two more questions, so feel free. Otherwise, Bob, I'll turn it back to you.
Okay, thank you, Stephen, and thank you, Alissa. That was really pretty wonderful. I'm really impressed with the challenging and vulnerable area you're working in with the population and the engagement of community and young people, and it's just really, really good work. And it's all relative. In my mind, you're a very you're still a very young adult. Good stuff. Thank you. Okay, so let's move on to our next presentation. And we've got Dr. Zoe Edelstein, who is currently the Director of Research and Evaluation for the HIV Prevention Program with Bureau of HIV at the New York City Department of Health and Mental Hygiene. And in this role, she oversees the prevention program's research and evaluation work, including evaluating activities, contracts, monitoring citywide trends, conducting special projects, including New York City's online home test giveaway. And Zoe, like many of our postdoc fellows, has been a wonderful ongoing collaborator and a really tremendous support to our HIV center. So thank you so much for being here, Zoe, and I'm turning it over to you.
Thanks, Bob. Can you all hear me okay? Great. I'm going to start.
Sounds good.
Okay, fantastic. I'm going to start sharing my slides. And can you see those okay?
Yep.
Fantastic. Thank you so much for having me. I'm excited to be here. I'm going to minimize all your pictures so I can see my slides. I'm excited. I'm very excited to be here at the postdoc alumni rounds. Today, I'm going to be talking about using research and evaluation to inform HIV prevention programs and policies with some examples from the New York City Health Department. So as an outline to this presentation, I'll first start out with just a little bit of background on HIV in New York City. I'm going to talk a little bit about missions and visions at the health department. And then the bulk of the presentation will be examples of projects where research and evaluation have informed HIV prevention programs. I'll specifically be talking about the examples of programs that I led, which include public health detailing on PrEP and PEP, and some information on the online home test giveaway, which will be abbreviated as HTG. And then there'll be a summary. So another way to think about this is some of the work I've been working on since I graduated from the postdoc 10 years ago. All right. So a little bit about the history of the HIV epidemic in New York City, and I'm sure many of you are aware of this. There's a vast and important history of the HIV epidemic in New York City, with many people in the room contributing. This graph summarized some of the data used by the New York City Health Department to track the epidemic, with the red line representing new HIV diagnoses, the green HIV-related deaths. The bars are people living with HIV or AIDS over time, and the black line being new HIV diagnoses. So as we know, the number of diagnoses increased starting in 1981 to the early 90s, and then started decreasing once treatment and syringe exchange and other interventions started working effectively. I'm going to concentrate mainly on new diagnoses, and we're really, these presentations are, and programs are in the context of the years 2014 to about 2020. And as you can see during this time, new diagnoses are going down, but still in 2021, there were just under 1,600 new HIV diagnoses in New York City. And importantly, inequities by race, ethnicity, and gender continue to be of greater concern as we work towards addressing bending the curve and ending the epidemic. So in this next slide, for additional context, as we leave academia for a minute, I wanted to present the mission and vision from the health department and the bureau and program in which I sit. I know all of you are probably familiar with the New York City Health Department, but maybe you haven't seen the mission and visions, which have been recently revised. And I think this helps set the stage for the bigger picture and our big picture goals. So for the health department, the mission is to protect and promote the health of all New Yorkers. And the vision is a city where all New Yorkers can realize their full health potential, regardless of who they are, where they're from, or where they live. And then the newly formed Bureau of Hepatitis, HIV, and STIs, or sexually transmitted infections, or abbreviated as BHHS. The mission is to improve the lives of New Yorkers by ending transmission, illness, stigma, and inequities related to viral hepatitis, HIV, and STIs. And the vision, a New York City without transmission or illness related to viral hepatitis, HIV, and STIs. And then the HIV prevention program, the program in which I sit. The mission is to vastly reduce HIV transmission in New York City and support persons and communities vulnerable to HIV. And the vision is we envision a city free of new HIV infections, where sexual health, well-being, and rights are protected, where sex and sexuality are not stigmatized, where equity is prioritized, and where New Yorkers of all identity live free of discrimination and justice. So I personally find that mission to be quite impactful. Sometimes it makes me a little emotional. And it really speaks to where we're trying to go and where we're coming from and where our goals are within the program. So the first example, as I mentioned, that I'm going to be talking about is the public health detailing program on PrEP and PEP, which was conducted between 2014 and 2019. Listed here are acknowledgements of many of the team members, some of which you might be familiar, including at least one postdoc alumni, Anisha Gandhi. Without these folks, none of this work would have been possible. So just in case you're not aware, I'm going to describe what public health detailing is. Public health detailing, you may be aware or probably aware of pharmaceutical detailing or academic detailing. Public health detailing is another way to, or another method of educating clinical environments. So representatives from public health agencies conduct visits or calls to clinical practices and engaged in one-on-one or small group interactions with providers and office staff. It provides a standard methodology for delivery of public health messages to key decision makers, and it's an effective model for selling, quote unquote, or promoting public health interventions through the targeted delivery of short, standardized, evidence-based key messages. So as I mentioned, this activity started in 2014, and at the time, the health department was doing many things to help promote PrEP, including promoting PrEP to potential users through social marketing, a provider directory. We were already working on promoting PrEP to potential providers through a number of programs, including technical assistance, implementation workshops, training for frontline staff, as well as supporting PrEP in diverse service models through our municipally funded sexual health clinics, the Place Share Network, and other assistance programs, as well as monitoring awareness and uptake. So in this context, why conduct detailing? Was, as you all know, at that time, PrEP was a new scientifically proven HIV prevention intervention. However, it was underutilized. And there were major barriers to prescribing PrEP among providers, which of course, some of these still exist. This include limited and sometimes incorrect knowledge, reluctance to discuss HIV and related behaviors among HIV negative patients, and of course, the well-documented purview paradox, where ID and HIV providers are comfortable with the HIV meds, but may not see HIV negative patients who would benefit from PrEP, and primary care providers who may see these patients, but may not be comfortable with prescribing HIV-related meds. So as I mentioned, we knew that PrEP was being underutilized by priority populations, and here's some data that helps us motivate this practice of working more towards getting PrEP to the populations who might benefit. So this is some data from the sexual health survey conducted by my team, the research and evaluation team in the prevention program. And this data goes up until 2014, wherein while awareness among MSM surveyed online was relatively high at 81%, only 7% reported PrEP use in the last 6 months. Another reason to do detailing is because it supports providers and promotes health equity. Wider dissemination of new public health policies, practices, and key evidence-based recommendations can be done through public health detailing. It allows for the distribution of materials to providers that are outside of our quote unquote comfort zone, or the people that we know through the health department or other networks. So these could be, as I mentioned, lesser known by the health department, providers or practice types who might not be expected to be early adopters of something like PrEP, and those who are just less able to attend HIV department trainings. Also, as I'll show later, we can use a targeted approach on who we decide to visit through public health detailing based on which providers we think will have the most impact. It also facilitates ongoing linkage to technical assistance with the health department and promotes equity by distributing information to providers through a targeted approach. So with this project of detailing on PrEP and PEP, we were standing on the shoulders of at least 20-year history of public health detailing at the New York City Health Department. So through those 20 years, a methodology had been established where there'd be a 10 to 12-week intense campaign where providers would be visited twice, once for an initial visit, and the subsequent half of this campaign, we would aim to follow up with all practices for follow-up visits. The detailing is one-on-one visits with healthcare providers. It's conducted by trained health department representatives, promotes adoption of recommended clinical practices to improve patient outcomes, and distributes supporting materials in the form of an action kit. And so one of these campaigns in that course of that 20 years, if you could see, I just put a red box around the action kit, but we had done a campaign prior to my coming to the health department led by Dr. Ben Choi on HIV testing. So for the PrEP and PEP campaign, additional descriptors that are important to know to understand how, the activity is that All of the visits were cold calls, so these were not scheduled with the sites or the providers. The representatives showed up, like as you might imagine, a pharmaceutical detailer showing up and just said, hey, is there anyone we can talk to about this new HIV intervention to prevent HIV? Also, the calls were full office visits. So while there were specific presentations for people who might be potential prescribers of PrEP, there was also presentations to those who would support this practice, such as administrative staff, nursing staff, who may be the champions that are needed to make this practice adopted by the office. And just a little preview, while we did one pilot campaign in 2014, over the course of 2014 to 2019, we did 6 campaigns around. So I'll be discussing a little bit of that chronologically later. So in terms of the key messages, everything around the campaign was around these specific key messages. And you'll note that these are sexual health inclusive. They don't just start with prescribing PrEP or PEP. The first is to take a thorough sexual history. The second is to screen and treat sexually active patients for STIs. The third is to talk about PrEP and PEP, which we know is an important step for people to initiate and also throughout their course of working with PrEP and PEP, and also important for creating greater awareness. And fourth, to prescribe PrEP and PEP according to clinical guidelines or refer patients to sites that could provide PrEP and PEP. So as I mentioned, all of our detailing campaigns have included an action kit, and this one supported all 4 of those key messages that I mentioned and was informed by stakeholders. So this included focus groups among providers and nurse practitioners, as well as key informant interviews. So the action kit included materials for the clinicians, both in the form of an FAQ and also cards that summarize some of the key practices, including taking a sexual history, PEP triage and PrEP assessment and laboratory testing, as well as materials for potential patients or people who are interested in PrEP. We gave them examples and then ways to order more. So one example of how this was informed by stakeholders is that we were told that it was very important to add something about how to finance PrEP for people who are not insured or uninsured. And so we also added I think it was a 1-pager on that, as well as at the time, the Gilead assistance fill-in handout that would be needed to apply for assistance for those patients. So as I mentioned, we use a data-driven model for site selection. We identified high priority practices, primarily using HIV and STI surveillance data collected by the health department. And for the first 4 campaigns, we focused on facilities specializing in infectious disease or ID and primary care, hoping to bridge that gap for the purview paradox. Sites were distributed throughout New York City in all 5 boroughs and included different facility types, hospital affiliated, private practice, community center, and those who were not already leaders in implementing key practices. And the picture on the left actually, or sorry, right, comes from one of those detailing visits. I believe that was in Staten Island. So there was a broad reach of this campaign. Over the first 4 campaigns, representatives visited approximately 1,300 facilities across New York City, interacted with over 5,000 clinical staff, and detailed almost 2,500 prescribing providers. So in the map on the right, each of the blue dots represents a practice visited. And as you can see, there's more concentrated dots in the areas that have higher diagnosis rates, as shown by the darker colors. So in terms of monitoring and evaluation, we use a database with line-level data on each provider visit. So the data that I just showed you from that map came from that database. We also composed and used a structured standardized provider assessment at initial and follow-up visits. There were also detailer field notes and weekly feedback and an online follow-up survey. So a little bit more information on the standardized provider assessment. This is a brief questionnaire that was conducted at both initial and follow-up visits. And it had a dual purpose, a programmatic purpose, as well as an evaluation purpose. So the first was to inform the approach for discussion. So you can imagine that a provider who says that they're unaware of PrEP would get a very different 10-minute presentation than someone who says they are aware of PrEP or are prescribing. The second purpose, of course, was to measure adoption of key messages and related knowledge and attitudes. And example questions are listed here. Did you take a sexual history from all patients? Have you ever prescribed PEP for non-occupational exposure? Have you ever discussed PrEP with your patients? Have you ever prescribed PEP to your patients? Data analysis compared provider response at the initial versus the follow-up. And we only looked at that data among providers who are queried at both. We also use GEE methods to account for providers who are at the same facility. So for the first 2 rounds, we saw positive change in key practices between initial and follow-up visits. In this graph, the solid bars are data from the initial visit, and the hash bars are the follow-up visit, which were about 4 to 6 weeks later. So if you look at the leftmost set of bars, knowledge of PrEP efficacy at 75% or higher, if taken daily. At the initial visit, 69% of providers identified this as correct, and at follow-up, just 4 to 6 weeks later, 82% gave the correct answer. And then if we go all the way to the right side, we can see ever prescribing PrEP increased from initial to follow-up visits. Again, these were just 4 to 6 weeks later. So went from 14% of providers saying they ever prescribed PrEP to 23%. And you can see the ends below the bar. This is among 969 providers. As I mentioned, we did a follow-up survey and we found that these increases were maintained 8 to 12 months later, although I'll note that this is a much smaller group. This only 102 people responded to our follow-up survey, which may introduce selection bias among other things. But we saw that PrEP provision really went up on that last third bar to 63%, PrEP discussion up to 79%, and PEP provision, which we didn't see any increase among that larger group, had increased to 54% 8 to 12 months later. So back to those initial and follow-up visits, and specifically focusing on ever PrEP provision, we also wanted to see whether by provider specialty and practice type, we saw comparable increases across these groups. So remember, overall, this was 14 to 23%. We looked by provider specialty and saw all of these differences, by the way, are statistically significant. We saw an increase from 23 to 40% among ID docs, 10 to 18% among primary care docs, 16 to 21% among NPs or PAs. And then also by practice type, we saw increases in all of these. Of course, all these groups also started at different levels. So we wanted to look into that a little bit further too. So we did a regression model looking at everyone who's visited for the initial visit, and found that it was 2 to 4 times higher of ever prescribing among ID providers, those who worked at practices in Manhattan, and community health clinics. So this really informed our next rounds. We conducted 2 more rounds in 2016 and 2017. We included, based on this information and elsewhere, we included a greater proportion of primary care providers, as well as, even though facilities were chosen in a similar manner, again, using HIV surveillance and STI surveillance data, we decided not to visit practices that had been known or suspected to be high prescribers, including community health clinics known to be prescribing, and a swath of clinics in lower Manhattan, which we knew were doing a lot of the prescribing at the time, both from our data and others. So in our third and fourth round, we saw some great increases as well. Again, the solid bar compared to the hash bar, we saw an increase all the way on the left of knowledge of PrEP efficacy from 69 to 96%. And then if we go to the right on this graph, We see an increase of ever discussing PrEP in purple from 64 to 74%. Ever provided PrEP did increase, though not statistically significantly. And we also added a question about a hypothetical question of would you provide PrEP? And this increased from 77 to 86%. So after these 4 rounds, we pivoted based on data and as well as conversations with the community and conversations with providers, understanding of the whole scope of PrEP and PEP in New York City. We decided to pivot to women's healthcare providers for rounds 5 and 6. We aim to promote the offer of PrEP and PEP to women in the context of comprehensive sexual health care. And these rounds were conducted between May and November of 2019. And that's a picture from the launch. Why women's healthcare providers? As you may all know, there is a disparity in prescribing among women. And at the time in 2018, women received 8% of PrEP prescriptions in New York State, while they were still 20% of new diagnoses. I'm not going to talk in total detail about this because we have limited time, but there is a paper by Wanish et al. That was recently published that you can find out more information. But briefly, these rounds were informed by key informant interviews and focus groups, action kit materials, messages, and site selections. Site selection were modified and adapted to this specific provider and patient population. And just as a snapshot, as a part of this program and the evaluation data that we saw excitingly increase in reporting of ever prescribing PrEP to women among detailed providers. So it increased from 44 to 57% among the primary care providers, 38 to 52% among women's health. ID and HIV and ID docs were already at a high level at 79% with no increasing there. But adolescent health providers also it reported an increase from 18 to 24%. And again, this is over a 4 to 6 week period. And this is just ever prescribing PrEP. We weren't measuring, to how many patients. So looking beyond the PrEP detailing program specifically, this data, as well as the program, has been used in training and resources throughout the country. We have conducted or supported multiple trainings to help support jurisdictions throughout the country, conduct PrEP detailing to providers in their locale and tailored to their needs. The picture at the bottom of here is a training that we conducted in San Francisco in collaboration with the San Francisco Health Department, as well as an organization called NARCAD. And there were, I think, at least 20 different jurisdictions there from all over the country. The kit materials have been used as foundational for other PrEP action kits. Excitingly, we just found out that detailing among women's healthcare providers is going to be added to the CDC's compendium of evidence-informed interventions for HIV prevention. Okay, so I'm going to talk about one more project area here. I'm going to talk about the online home test giveaway from 2015 to 2020. Again, these acknowledgements are people who we could not have done this project without. And I just want to thank them now and make you all aware that this, it takes a village, as with many projects. So I've spoken a little bit about this project before, so I'm going to try and do a concentrated presentation here based on data and how it moved the work forward. But just by way of some background, as many of you are aware, the US FDA approved the self-test in July of 2012 for over-the-counter rapid test for personal use. The thought is that it would help address barriers to testing, including concerns about privacy, stigma, and hesitance to seek testing in clinical settings. However, there are potential barriers, including awareness, the price at $40, and at the time, only approximately 1 in 4 New York City pharmacies had it available. So to address the self-test barriers, giveaway programs started to pop up after FDA approval. And as of 2015, Los Angeles, Washington State, and London had all started experimenting with these. So in 2015, the health department launched the online home test giveaway pilot. The aim was to distribute self-tests to MSM and transgender individuals who have sex with men. The test would be sent at no cost through the mail. The whole thing would be conducted entirely online. And this was all informed by community stakeholders, as well as many conversations, formative research with these other giveaway programs, as well as giveaway programs that have been conducted, not just for the self-test, but for other items in New York City. The flow of this campaign for the participants was and continues to be that they view the campaign ad online and click on an eligibility survey. They answer basic eligibility questions. If eligible, they receive a discount code via email immediately, and then they're directed to the manufacturer's website or Assure to place an order, which will come to $0. They then receive the test package by mail, and then we invite all eligible participants to do a follow-up survey. If ineligible, they're directed to NYC Prevention and Care resource websites. The eligibility survey was very brief and assessed eligibility, which was all of the following: cisgender men and transgender or gender non-conforming individuals, men that have had sex with a man in the past 12 months, reside in New York City, age 18 or older, and no previous HIV diagnoses. The eligibility survey, as brief as it was, also included information on race, ethnicity, and time since last test to see who we were reaching. There's also a follow-up survey, as I mentioned, which collected data on test receipt, use, experience, result, and recent HIV-related behaviors, and participation for that was incentivized by a $25 gift card. I'm going to concentrate on the variables from the eligibility survey in the next set of slides, particularly race, ethnicity, and time since last test. So this is just a small selection of the demographics that we could look at among participants in the home test giveaway. And this is just for the pilot round in 2015. As you can see, most participants, well, I'll start with how many participants there were. There were just under 2,500 participants. Most participants were cisgender men. And in terms of race and ethnicity, there was a diversity of folks. However, improvement could have been increased, or could be seen. And I will talk about that a little bit in the later slides. So one of the most important results that we got out of this is that of the people participating, 14% were reporting that they had never tested for HIV before. And just for some context, when that question is asked among participant or clients, excuse me, at the municipally funded sexual health clinics, it's 5.6%. And at New York City funded clinical and non-clinical prevention programs, it's 3.5%. So this was a really compelling piece of data to keep this program going and really turning it from a pilot to a program at the health department and beyond. So after the successful pilot, 6 more home test giveaway waves were conducted. We used a similar model, but used some innovations to add more kit to the inventory, broaden the reach of marketing and length of the campaign, offering surveys and resources in Spanish, and ads with transgender and gender non-conforming persons. So over the course of 7 waves, over 38,000 people have been screened for this giveaway. 23,000, over 23,000 determined eligible. And this important number is 16,762. And that's the number of self-test kits that have been sent out through the home test giveaway throughout its history. As I mentioned, we were going to look at race ethnicity among eligible participants later. So this graph shows the distribution by wave. So each The y-axis shows the wave number, with the first one being the pilot, where we saw that 14% of participants were Black, non-Latino, and 30% were Latino or Latina. By the 7th wave, those numbers were 19 and 36%, which is an improvement, but as I mentioned, there's still room for improvement there. And this was done again through a diversity of images, as well as the sites that were being used for social media. Again, this is gender over time, and we do see an increase from the first wave to the last, from 1 to 5% of folks who identified as transgender or gender nonconforming. However, again, still room for improvement, and we're actually working on an exploratory study to increase this participation. And this is, I think, my last data slide. This is prior HIV testing. And as I mentioned, this was a very important data point for us keeping this project going. And the group that had never previously been tested in this graph is the purple slice of the pie. And the 18% is the average over the 7 waves, with a range of 12 to 25%. So in other words, this number remained high. I see a question from Christina. I'm gonna finish and then I'll answer it if that's okay. All right, so the implication and adaptations to other settings. So due to the success of this model, we expanded our partnership with New York State, and they are now independently conducting their own home test giveaway, as well as different iterations on that model. We've done a lot of capacity building assistance with other jurisdictions and on a national level. An example is a CEBA seminar or capacity building assistance webinar that you can see a link from at the bottom here. Also, just to note, there are limitations to this model. And so due to those limitations, adaptations and different programs have been able to be formed. So one of them is the community home test giveaway, which has been presented prior by Maria Ma in this context, and Stephanie Hubbard. This is a program where the recruitment is done specifically by CBOs and other organizations rather than by the health department, and has a much wider eligibility criteria. And then also other exploratory work for future adaptations. As I mentioned, we're working on a project to better serve TGNC individuals. Also, home test giveaways are all over the place now, being used by multiple jurisdictions across the US and on a national level. And you can see all the states that are doing these in the link that I provided at the bottom of the slide. So those were my 2 examples, and I'm just going to summarize pretty quickly, and then I'll be excited to answer any questions anyone has. So in summary, data-informed pilots at the health department have help support new intervention uptake in the initial phases of eligibility, PrEP and PEP, PrEP and the self-tests. Both of these programs that I described were within the first 3 to 5 years after these were FDA approved, and we were able to pilot and then continue those programs based on information gathered. Also, evaluation data can be a powerful tool to support program sustainability, inform program improvement, improve equity and access, which is very important, and also can motivate other public health programs and researchers across the country. We were told, by smaller jurisdictions or jurisdictions with less funding, that by using our programs as an example, they were able to convince leadership to do smaller but similar programs within their own jurisdiction. And lastly, our mission and visions are supported by incredible teams. I showed some of those in our acknowledgements throughout this presentation, but there are so many more to name, and so many more who really are interested in making this vision that I mentioned before, the perfect HIV prevention vision, a reality. So going back in time a little bit, since this is the postdoc alumni event, I would be remiss in my cheesy self not to also do a little postdoc appreciation moment from everyone from my cohort and my mentors and the directors of the program. They're all doing incredible things in the world. And if they haven't presented yet in these rounds, I look forward to them doing so. Thank you.
Thanks so much, Zoe. That was great. Great to see those two examples. Do you want to answer Christina's question now?
Yeah, let me read it first.
I can read that one.
Okay, go ahead.
It seems like prevention is doing a lot of implementation science and practice. Are there any implementation science theoretical models or frameworks that you all use to guide your planning and evaluation efforts?
Yeah, that's a great question. I think, you know, at the time we were following some of the more of the evaluation methods and models that were given to us by CDC, basically using evaluation in an iterative process to improve over time. I can see the cycle, but I don't know what the name of it is. And that's really what we were going, the model we were using. But since 2014, implementation science has just blossomed, although maybe it was blossoming then too, and we were unaware, but it's really blossomed. And we are working on at least 3 or 4 implementation science projects with academicians to think about implementation by clinical environments, as well as our own Place-Share network, as well as the project that I was speaking about to reach transgender individuals and gender nonconforming individuals, which we'll be using an implementation mapping model I'm working on with people from the HIV Center as well as community members. Thanks for the question.
Great, thanks, Zoe. We have a question from May. May, go ahead.
Thanks. Zoe, I wanted to ask you a little bit about the policy piece of the work that you do, because you do all this wonderful research in the community, learning about how to increase uptake and work with providers. But when you talk about policy, do you mean policies of the providers themselves, or policy at the city level or the state level? And how does that transformation take place? Like, how do you get from all the research and move toward something more formal like policies?
That's a great question. And I will say I'm not a policy advisor, but our data has been used to inform. My colleague Adrian Guzman is the director of policy within our bureau, and has been used to inform our recommendations for legislation going forward. And that's done on a calendar in terms of like what legislation is being put forth, and the health department can give recommendations on their understanding of that legislation. And this data has been used to help inform that. And then, of course, there's also internal policy and how we choose to use the funds available to us, and which way we want to go forth with that. So I think that's not really like an official definition of policy, but given the largesse of the health department and the funds that are available to us in HIV prevention and care, it's important that those are informed by the data that we collect citywide and through our programs.
Thanks. So based on your experience, would you say that research has had the power to make really important and effective policy in the city?
That's a big question. I feel like we have influenced policy. Effective policy change, I would want someone else to answer.
It's just good to know the powers out there, though.
Yeah, the powers out there, can talk to each other, and sometimes they don't always agree. But I think it's really been a wonderful experience working with my policy colleagues who are aware of the work we're doing and are constantly checking in to see if we have any data to support the efforts that they have, or support or inform the efforts that they are working on.
Great, thank you.
Thanks, May, for your question. We have a question and comment from Phil. He says, classic photo of you and John at the equator. Do you think your provider prep work or other work you presented today could be applied internationally, for example, in Uganda?
Oh, that's a great question. The self-test work, I mean, I think, Alissa, you all are using self-tests. And we know of other self-test giveaways that are being done all over the country, excuse me, all over the world. I was particularly impressed with a program coming out of Brazil a couple of years ago that were sending self-tests in a similar manner, but it also set up like a whole client support network through like texting and other ways, so that people who had no resources for HIV related clinical practice, or not clinical practice, but they didn't have a clinic to go to or someone to talk to, or just didn't feel comfortable talking to it, they were able to hook into that as a part of that process too. In terms of prep detailing, I think yeah, I think it could be used in other settings. Oh, sorry, you asked about Uganda. I mean, I think the self-test could be used in Uganda if it's not already being used. But in terms of the detailing, that's a really interesting question. You know, the US healthcare system is a unique and somewhat, well, I'll just call it unique system. And I don't know how much that translates to other places, but I assume that still there would be providers who'd be less likely to want to talk about HIV related subjects with HIV negative patients, as well as those who are less informed about these interventions. So I think it would definitely have to be adapted to the setting, but I don't see why the general model wouldn't be something to explore. Great question.
Thanks, Phil, for your question. Yeah, he wrote a comment. Yes, just thinking about the provider detailing, given that oral prep is now available in rural Uganda, but uptake or prescription is still very low.
Yeah, I mean, I think you still have to have some measure of providers who are willing to be early adopters for it to work. So if the barrier is just too high, you might not want like a public health detailer. You might want like a peer detailer, someone who's also a provider. If folks think that will be an easier way to convince folks to start adapting that behavior.
Great, thanks, Zoe. And thank you, Phil, again. We have a question from Susie. Did I understand correctly that the PrEP and the PEP detailing pilot did not become an ongoing program? If so, why was that?
Oh no, that's, sorry, if I said that, I misspoke. It's I was just calling the first round of it in 2014 a pilot, but we did it 6 more times. The last round we did was in 2019. It is a lot of work to get these off the ground, and particularly in times where we are still in COVID response, walking into a practice, it's harder to do. I don't know what that would look like, but we do have colleagues who are working on detailing on immediate ART, and they're doing online detailing. That requires setting up a time with the providers, which has its pluses and minuses. As we all know, scheduling can be difficult, but the online component allows them to continue to work in this environment where it's, clinical practices are a little less open to people who aren't, the one patient being seen on that day.
Thanks, Zoe. We have time for 1 or 2 more questions. Last call.
Hi, Stephen.
Go ahead, Teo.
I see thank you on my screen and I don't see Zoe, but I would like to say.
I'll stop sharing.
What I would like to say to Zoe is that this is so impressive, and you, of course, you stress again and again that this is the work of a large group of people, and this can only be done with a large group of people. But at the same time, you're in the middle of that, and it's wonderful to see how much can be done and how much you have been doing. I'm really impressed, and yeah, very good to see this. Thank you so much.
Thank you, Theo. That's really nice to hear. I was thinking about this actually as I was about to present. You know, some of this is right time, right place. But some of it, of course, is yeah, the ability to work with these teams and the availability of funding, and really, you know, big thank you to a lot of people on this call. Some of this was initiated as a part of ETE funding or sustained as a part of ETE funding. So yeah, there are so many people to thank for this.
I would like to add one thing, Zoe, but I also really admire is the impact that you have as a local Department of Health on the rest of the United States and beyond. That's really rewarding to see.
Thank you. It's been very rewarding. And actually these practices have been adopted federally now and are written into some of the federal funding announcements. And they've just become totally diffuse. Like, people are doing it in all different ways as they can and as works best in their locality. So I expect that if we looked into each of those home test giveaways, they would, you know, not look exactly the same as we have conducted it. But I think also just the health department during that time was brave. I mean, there were definitely people who challenged the idea of doing a self-test giveaway for reasons that folks could probably guess. But the same reasons why, you know, people see challenges with self-tests in general, that, you know, the person isn't there with a clinician when they get the result, was a really big challenge. And also, will we get the data, blah, 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 blah. But I think once people saw this powerful statistic specifically of never testing and, you know, reaching this group of people that we hadn't reached before, it really became important to continue the program.
Thanks.
And we have a comment from Susie in the chat. She agrees with Theo and says, fantastic.
Thanks, guys. I really appreciate that.
If other questions, Bob, I'll turn it back to you.
Okay, thanks again, Stephen and Zoe. That I you know, ditto on everything that everyone said, particularly what Theo said. I was just thinking exactly the same thing, that it's just really powerful and important work, and you know, you're really at the forefront of this, you know, and so and both of you, Alissa and Zoe, it's really, we're so proud of you and happy to call you ongoing colleagues and part of our HIV center. And yeah, that was great, Zoe. I just think that, you know, like was already said, the influence and the impact, you know, across the country, and definitely I see it, you know, and I work in, as you know, in the HBTN network and a lot of other large networks, and just see the influence of the work coming out of the New York City Health Department. So that's really pretty wonderful. Okay, thank everyone for being here. Thank you, and hope to see you in 2 weeks on the 26th for our next grand rounds. And thank you again to both Alissa and Zoe. Have a great rest of the day, everyone, and a good couple weeks. Be well.